Okay. Thank you, Evelyn. You can continue.
Great. So with that being said, the floor is yours, Dr. Gillian, Dr. Pinho. Thank you so much.
Okay, well, Emily, do you want to go first since you have more experience than me? And you can
No, go ahead.
All right. Well, I'm Jillian, and Emily and I both work at UCLA as nurse anesthetists. I was hired in June of 2020, so I've only been there for about a year and a half. Prior to that, I was in school for 3 years to get my nurse anesthetist degree. And I got a doctorate degree. It's trending that way now, but a lot of programs used to be master's programs. So that's why technically, like, I am Dr. Queen, but I don't ever refer to myself as that because I don't want to confuse patients because I'm technically not like a medical doctor. But I do have my doctorate in anesthesia, but it's a nursing track. So I know it's very confusing. I'm a doctor nurse, I guess. And prior to the degree becoming a doctorate degree, it used to be a master's degree. So you'll still see a lot of nurse anesthetists out there who have a master's degree, which is only 2 years as opposed to 3 years. If you have questions about that, you can ask me like what the difference is between the master's and the doctorate, and because it's perfect because Emily has her master's, so we can kind of share what the difference is. But typically the track to becoming a nurse anesthetist, you go to undergraduate school, you get your bachelor's of science in nursing, which I did. And there's several ways you can do that. You can do an accelerated bachelor's program, which is 1 year in length after you've completed a majority of the science courses. And that's what I did. So I did like 4 years of undergrad at University of Michigan. I did a bunch of science classes. I majored in biopsych. And then I went to a second degree program, which is 1 year. And that's where I got my bachelor's of science in nursing. And then after that, I came back to California because I'm from California. I worked here at Little Company of Mary in Torrance for like a year and a half. And then I wanted to work in the ICU. So at the time, a lot of ICUs weren't hiring. So I actually moved to Nashville and I worked at Vanderbilt because all the ICUs there were hiring. So that is one tip from me, is if you want to get into the ICU and you can't get into the ICU, you could always be willing to move somewhere and get that experience, and then you can go wherever you want after that. So after I worked in Nashville for a little bit, about 2 years, I moved to Chicago for a boy, which don't do that. And I worked in the ICU in Chicago at University of Chicago and University of Illinois at Chicago. And I floated amongst all the ICUs at both hospitals. And I did that for about 4.5 years, and I loved it because of the variety. And then after that, I spent a little bit of time in the OR because I thought I wanted to be an OR nurse. But it turns out I wanted to do the anesthesia part. So I went back to school for anesthesia. In order to become a nurse anesthetist, you have to work in the ICU for at least a year. Most people have a few years of experience before going back to school. And some programs will only accept adult ICU and not pediatric ICU. And some will not accept ER experience. Well, most don't accept ER experience. But yeah, I had a total of like 7 years of nursing experience before I went back to school. And it's good and bad because you get a lot of experience, but also I get more tired going back to school and I forget more. So I have to study more. So I guess that's something to think about. Yeah, so I'll talk about the doctorate and then Emily can talk about the master's. This is a question in the chat from somebody. So the doctorate program is 3 years, and the first year is you come up with like a research question. And it's a really, really basic research question because you can't technically like do anything that's really invasive with patients. So it could be like a survey, or it could, so my project was measuring nasal nitric oxide levels in little kids to see if the kids with higher nasal nitric oxide levels had higher incidences of adverse airway events under anesthesia. And I basically just had this little tool that I put in the kids' nose when they were sick and told them that I was going to measure the number of boogers they had in their nose. And then we did like a statistical, analysis of the whole thing. And it was actually really interesting. So that was like the first year of the program. And then the last 2 years are like really heavily clinically based. And so the other 2 years are pretty much very similar to the master's program, I would think, because you're in the classroom and in the hospital. Does that answer your question for the doctorate portion? Okay. So I guess I'll let Emily talk about her journey to becoming a CRNA.
Hi guys, I'm Emily Pinu, and I do not have my doctorate, so please don't call me Dr. Pinu. I go by Emily. Thank you, Evelyn, for setting this up. This is a really nice little forum. So I have been a CRNA for 6.5 years. I also was a nurse for 6 years before I went back to school. So I graduated way back in 2007 with my bachelor's of science in nursing. And my first job out of nursing school was in the ER. I used to work ER trauma in the middle of nowhere in Missouri. It was like a receiving trauma hospital where everybody would helicopter in from their like farms and their like, cow ran over me traumas in the middle of nowhere. And it was a really fun first job. Like I worked there for just under 2 years and got my feet wet in nursing. I came to California as a travel nurse, actually, initially. I also worked at Little Company Mary in Torrance. That was my first travel nurse job, actually. I was in the ED there for, I don't know, probably 2 years or something, back and forth. And then I took travel nursing, took me up to Alaska. I went up there for 3-4 months or so, also worked in the ER. And then I came back to California to take another travel job. I kind of went to Kaiser. I went up to a place in Glendale. I kind of jumped around a few hospitals on like 3 to 4 month assignments. And then I ended up settling in the ER at Kaiser South Bay, which is down in Culver City. So I was there for a few years, and actually I kind of got pretty burnt out. I'd been a nurse, I think, for maybe 5 years or so. My entire career had been in the ER, and I was pretty burnt out. So I took some time off. My then boyfriend, now husband, and I moved to New Zealand, and we got jobs working as waitresses and waiters at a hotel restaurant for a few months. And we traveled around the country and totally goofed off. And it was at that point that I was like, okay, if I'm going to go back, I need to have like something else to, I want to have something else to do. So that's when I decided to start researching and looking into being a nurse anesthetist. So I actually came back and I was working at Kaiser, and I shadowed, they have a lot of CRNAs that work at Kaiser Harbor City. And I asked if I could shadow one of the CRNAs. And in the meantime, I interviewed a bunch of nurse practitioners as well, because I was trying to decide, do I want to go back and be a nurse practitioner? Do I want to be a nurse educator? Do I want to be like a clinical nurse specialist, or do I want to be a CRNA? Those are like kind of I would say the primary 4 tracks for like advanced practice nurses. So I interviewed a bunch of nurse practitioners, and then I went and shadowed this one CRNA, and probably within 2 hours of shadowing that CRNA, I was like, this is what I want to do. Looks like fun. He's like controlling everything about the patient during surgery. He's controlling their breathing. He's controlling their blood pressure. Like all this, it just looked like a lot of fun. So I immediately, that's what I want to do. And I immediately applied for a job in the ICU. I went and worked in the ICU at St. Francis over in Linwood. And I literally did 1 year of ICU there. And while I was in the ICU there, I studied for the GRE and took the GRE. So I was like, if I'm going to do this, I'm going to do this all quickly. So I got my year done. I got my GRE studied for. I took a physics class, and there's some other prerequisite. Oh, statistics. I took statistics and physics again online. I did it at like University of Phoenix. And then I applied immediately to the CRNA program at USC. So I finished, when I went to school, there were very few doctorate programs. So when I went, it was literally exactly 2 years. It was a very intense program. It still is a very intense program, the master's or doctorate. And it's basically you just kind of sign away 2 years of your life. And at the end of it, though, you have your program, like your knowledge base, and you also have your experience, your clinical hours. So at the end of the program, whether it's a doctorate or a master's, you're basically prepared to immediately go into the operating room and take care of patients. So I started working at UCLA in 2015, and I've been there ever since. I also work private practice here and there. Right now, I'm primarily at a little GI center here in Torrance. That is, when I say private practice, it means that the billing is set up a little bit differently. I don't work for a hospital. I work for myself, and I just bill. I actually don't bill the patients directly. I bill the owners, like the company pays me directly, but it's a little bit of a different practice model. So that's my journey. I see a note in the chat. Has ICU nursing helped be a CRNA? So yes, I would say that being a nurse in general prepares you for being a CRNA. When you're a CRNA, the kind of common concept among lay people is that you go into the operating room and you just get a drug and fall asleep, and then you're asleep for surgery and the surgeons do all the work. In reality, if you're having, say, your ankle worked on, the surgeon doesn't know that you're a person other than your ankle. The surgeon has no idea that there is a heart and lungs and brain anywhere attached to the person. So the CRNA is responsible for the rest of the entire patient's body during surgery. So you, as the CRNA, are helping with, or you're manipulating their breathing, you're giving medication on and off throughout the entire surgery, you're adjusting their anesthetic gases, you're giving medication to bring up their heart rate or lower their heart rate, to bring up their blood pressure or lower their blood pressure. You're giving pain medication, you're giving anti-anxiety medicine, you're giving muscle relaxant so the patient's not moving. You're doing a lot of maintenance during the surgery. And the way that nursing really helps, especially ICU nursing, is that as an ICU nurse, you get really comfortable with controlling hemodynamics. So a patient comes into the ICU, say with sepsis, and their blood pressure is low. You as the ICU nurse are constantly adjusting drips and maintain, to keep their blood pressure up. You're maybe giving some medications when they have an arrhythmia to treat their arrhythmia, to keep their heart rate down. And you become very comfortable with emergencies or with hemodynamic monitoring and hemodynamic managing. And that's kind of spills over into what we do as nurse anesthetists. I don't know if Jillian has more to expand on that. That's just my take.
I agree. I will say when I went back to school in my 30s, the nurse anesthetist and the anesthesiologist that I worked with asked me if I had been a nurse for a long time, because they could just tell, because I think I just was like more in tune with the environment of like all the beeping and the monitors versus like somebody who has only had 1 year or 2 years of ICU experience.
Yeah, I would definitely recommend, if you're thinking about going back to school to be a CRNA, plan on a good 2 years of practice. Most programs require 2. Some of them are okay with 1 year, but it's kind of hard to get really comfortable and confident as a nurse in your first year, because at least the first 6 months, you're kind of just learning how to be a nurse, So I would recommend getting a good solid 2 years.
Agree. Also, the application process takes about a year. So keep that in mind too.
True. Yeah, that's true.
Mm-hmm. Another question is, if there's one thing we can concentrate on in nursing school now to assist with succeeding in CRNA school, what would that be? I guess it would be your ICU rotation, and just focusing on the critical care aspect of school. Emily, anything?
Yeah, I would say get good grades in nursing school because they actually do consider that when you go into grad school. You don't have to have a 4.0, but they, it's a really competitive program, getting into nurse anesthesia school. So, like when I applied, the school I applied to, I think had 200 something applicants and they allowed 16 in a year. And that was at USC. And then I know Kaiser has a program, a couple here in town. Kaiser is one of them. They have like 300 or 400 a year. And I think they were letting in like 30 something. So it's really competitive. So things that you can do to increase your chance is to have really good grades in your undergrad program, in your nursing program. And then as soon as you get out into the real world and get like 6 months of experience in critical care nursing, get your CCRN, which is like a ICU certification. And while you're here in nursing school, like Jillian was saying on your ICU rotations, I would recommend like treating every day in clinical like it's a job interview, because it can be hard to get a job in the ICU right out of school because it's really intense. So study up on your patient, like ask questions, treat each day like they're looking at you and considering you for a job, because they kind of are. Evelyn asked, do you think CRNA school helped prepare you for what your job is like now? Absolutely. CRNA school is basically there's training like in classroom and research, but the most major component of CRNA school, I would say, is time in the ER, or in the ICU, I'm sorry. I mean, in the OR. I can't figure out what I'm talking about. There's a time in the OR where you're actually practicing. So you get paired up with a practicing CRNA and you spend 40 to 60 to 90 hours a week in the OR taking care of patients, and being trained by CRNAs and anesthesiologists to eventually be a CRNA. So by the time you finish your training program, you may not feel 100% confident and comfortable on your own, but you're ready to go.
Yeah, in school, there's a heavy clinical focus. So when you're in school, you will also do everything that a CRNA does, which includes working nights sometimes, taking call sometimes. And when the nurse when the CRNA that you're with that day goes to lunch, they leave you in the room by yourself if you're a more senior student. So by the end of the program, like let's say in the beginning of the program, you start with 2 days of clinical. By the end of the program, you'll be in 5 days of clinical. So you're just in the OR all the time and you will be left alone, and it'll be just like you are a nurse anesthetist on your own. Okay, let's see. There's a question that I'm reading. How many hours do you typically work in a week? I imagine it's quite a bit more than bedside nursing. Well, Emily, my schedule and Emily's schedule is a little bit different because Emily goes to one other place within the UCLA system that requires her to work nights and weekends and holidays. So her schedule is a little bit different, but for me, I work 4 days a week and I work 8 hours, 10 hours, or 12 hours. Typically as a nurse, you work 12-hour shifts if you're working in the ICU. There are like nursing shifts, there are like other nursing shifts that are shorter, but they're usually like in other areas like outpatient surgery or something like that. And what is the math like in terms of prerequisites for CRNA school and in practice during procedures? Let me just tell you, I'm really terrified of math, even though I'm Asian. So it's like really ironic, but I'm not good at math by any means. I was an art major. And so I was terrified of it, but honestly, it's not that bad. It's a lot of moving decimals around, I would say. It's like converting micrograms to milligrams or like percent of a solution. You just learn to move the decimal point around, and it's not too bad. It's weird because we use like the metric system. So we do kilograms and all these other measurements that we don't ever use any time else in our lives, but you get used to it.
And thankfully, there's so many like things to help you even as a bedside nurse or as a CRNA. Like the pumps all have like max amounts and minimum amounts. So you kind of have checks and balances that will help you not make a mistake. And honestly, I don't know about Jillian, but for me, if I'm like, wait, I haven't given this drug before, I'm not 100% sure of this calculation, I'll just have like the nurse in the room double check it with me. Like, wait, I might be having a dumb moment. Can you just do the math? Like also and make sure I'm not being an idiot. And everybody's
Yeah.
always helpful.
There are also apps out there that they've made now that makes conversion really easy. So it's almost fail proof.
Yeah, true. There are two questions about the responsibilities or the difference between a CRNA and an anesthesiologist. That's a great question. Basically, if you walked into the operating room and looked over at who's doing the anesthesia, you would not be able to tell the difference between a CRNA and an anesthesiologist. Obviously, there's a difference in our training. So an anesthesiologist, at least in the US, is a medical doctor that goes through undergrad in whatever, it could be pretty much any science-based undergrad. And then they go to 4 years of medical school, and medical school prepares them to go to residency, any residency. Medical school is the same pretty much for any specialty. So after medical school, they then have to spend 3 to 4 years in training to become an anesthesiologist, where they're learning anesthesia specific management, and they are training with anesthesiologists and CRNAs in the operating room. Whereas becoming a CRNA, as most of you probably know at this point, is you go through your undergraduate, your 4-year degree in nursing. The requirement is then to go a couple years after that of bedside nursing and critical care, like we talked about, usually the ICU. And then you go back for now a 3-year doctorate program in specifically in anesthesiology. And that 3 years is kind of a combined component of all the didactic or the classroom knowledge of anesthesia, as well as the OR training portion of anesthesia. But then after you get out of training as a CRNA or an anesthesiologist, most of what we do looks exactly the same. You are in the operating room, you're pre-oping a patient beforehand, you're looking them up, you're getting their medical history, you're consenting them for anesthesia, you bring them into the operating room, you handle all their medications and all their hemodynamics in the operating room, you intubate them and place them on a ventilator. That means put a breathing tube down to their lungs, place them on a ventilator to help their breathing during the procedure. At the end of surgery, you wake them up, you bring them to the recovery room, you write orders so that the recovery room nurses can take care of them. It's exactly the same. And then of course, if you're covering women having babies, then you're, placing an epidural and managing their pain control while they're in labor. There are different types of practice. This is a little bit technical, but in the way that Jillian and I work at UCLA is in a supervised practice. So this means that there are anesthesiologists and CRNAs working together. So usually the way that it is there are CRNAs in each of the rooms, and then there's one anesthesiologist per every 3 or 4 CRNAs. So say Jillian and I are both in a room Jillian's doing foot surgery and I'm doing hernia repairs, and another CRNA is doing another case next door, and then there's one anesthesiologist that is kind of our backup. They're considered the supervising anesthesiologist, and they're there to assist us if there's an emergency, if there's a difficult airway. They'll often come in and push drugs for us because we're holding the mask on the patient to breathe, so they're pushing drugs or an extra pair of hands, and there are our supervising anesthesiologists. Now, in private practice, like when I work at my GI center here in Torrance, there is no anesthesiologist. I work independently. So it's there are differences in our education path, and there are differences in terms of models for billing, which is basically what the supervised practice is. But in practice, the actual hands-on is pretty similar. Now, one caveat to that is I will say there are lots of fellowships that anesthesiologists can do. So it's kind of rare for CRNAs to be a sole provider for cardiac anesthesia, like open heart procedures, or for liver transplants, or for neonates. So those are things that an anesthesiologist, after they already become an anesthesiologist, they then go get a 2-year fellowship in just hearts or just brains or just babies. And those are things that, as of right now anyways, I don't think there are too many CRNAs that specialize just in that independently. Sorry, that was a long answer.
No, that was really good. I will say, when you add up the amount of years of how long it takes us to become a CRNA versus how long it takes a med student to become an anesthesiologist, it's the same amount of years now. So that's just something to keep in mind. do you feel like you have a better work-life balance as a CRNA compared to bedside nursing? I definitely do think so. Bedside nursing, I was working 12-hour shifts all the time, and I felt like I had no control over my schedule. But I also think it's institution dependent. UCLA is like really accommodating for the most part, to like when they can be to our like what we prefer. So we can always tell them like what our preferences are. So it does allow like a nice work-life balance for me right now because I'm not working weekends and holidays or taking call or working night shift. Well, we do a minimal amount of weekends, but how do you feel, Emily?
Yeah, I
Similar?
think I agree with you. I think the work-life balance is a little, I think you're just not running so much like you are as an ICU nurse or as an ER nurse. You know, we were on our feet all the time and honestly, you get treated much better by patients and by hospital staff. And that alone just makes you feel like you're not as exhausted at the end of the day, I think.
Yeah. And as bedside nursing, like you have to work in the hospital. Whereas like as a CRNA, you can kind of, if you don't want to work in the hospital, you don't have to work in the hospital. You can work in outpatient settings. You can work like at a cataract eye surgery that only does cataracts from 7 a.m. to 3 p.m. And there are lots of like travel positions for CRNAs as well, like that they're texting me all the time because I went to school in Pittsburgh. They're texting me about jobs in Pennsylvania that are like, in 2 months in duration, and it's like 7 to 3, Monday through Friday. So yeah, you can kind of make it what you want it to be.
I think RP asked if we recommend getting some experience in the field before going to CRNA school or go straight to master's or doctorate. I don't know if you were here at the beginning, or I'm sorry if I'm not pronouncing your name right. I think it's RP. But we kind of went over in the beginning about how you actually is required to have at least one, usually 2 or 3 years of experience as a bedside nurse before you can go get before you can go to CRNA school. You can't finish your undergraduate and get your bachelor's in nursing and then go directly into CRNA school. If you look at the prerequisites on the websites for every single CRNA school in the country, they all require, I think every single one, they all require at least one, usually 2 or 3 years of critical care experience, which means ICU. Sometimes they'll accept ER or pediatric ICU experience also.
All right. What is the hardest part of CRNA school? Obviously, the coursework is intensive. I was one of those students that never really had to study, and I would get B's and I'd be fine. But I tried to do that in CRNA school, and like I couldn't get by. Like I actually had to really study. So I would say like the coursework is tough, and that's why they make sure you have good grades going into the program. But I will say like probably once you are in the program, the hardest part for me personally was realizing that there are a million ways to do anesthesia, and everybody has a preference for how they like to do it. And as a student, you kind of do it how they want to do it because you're with that person that day. And so it's really hard sometimes to figure out what you like when you're kind of being told by other people like what they like to do. So I mean, that's a little bit more technical, and you won't really understand that part, I think, until you're in the program. But as I had mentioned before, I was an art major before, and I thought, man, I'm going into something that's like totally not like art. It's like completely different. But actually, anesthesia is really artistic because there are so many different ways that you can give anesthesia. You're basically like making your own recipe for anesthesia for this patient. You're tailoring it to a specific person and their needs. And it's really neat because you get to be creative and you get to decide like how you want to do the anesthesia. So I think that part of it is really cool. And it allows my like artsy side to come out. And yeah, what about you, Emily? Anything to add?
Yeah, I think I kind of agree with you. Honestly, the hardest part of CRNA school is getting into CRNA school. And then it's just the time commitment, you get used to I know you guys are in school now, but like when you're out of school, you'll start probably getting used to working 3/12s a week. And so I was used to having like 4 days off a week to go do whatever I wanted to do. And then you go into CRNA school and you're working sometimes 12 hours, 5 days a week, and sometimes more. And then you have to study on your downtime. So it's just a big time commitment. But that said, it's totally doable. I mean, if you guys can make it through your undergraduate in nursing, that's the hardest undergraduate degree in the country right now, and you guys are doing it. So I'm sure that if you can get good grades in nursing school and can graduate from nursing school and pass the NCLEX, I'm sure you can get through CRNA school if you can just put the time commitment through there.
The other hard part is that it's not paid. So when you're in school for 2 to 3 years, you're living off of loans and it's not paid. For the GRE, I actually used Kaplan and I found it pretty helpful.
Yeah, I was similar. I used the Princeton Review book. I just went to the library and got it. Do it when you're like relatively close to being out of school, because you're still kind of in study mode. It's much easier to like learn new math, quadratic equations and all that crap that you don't use since high school. So just do that when you're like still in study mode right after school.
I will say when you graduate from nursing school, you have 5 years before your science courses expire. Because I was like Emily, I had to retake physics and statistics, and I did it through University of Phoenix as well. But it does suck because you're like, oh my gosh, I took these classes and they were terrible the first time. So
That's true.
Yeah.
I was asked, I think this is a direct message, but I'll read it to everyone. I was asked if the responsibilities are so similar between CRNAs and anesthesiologists, is the pay close? So it's kind of a complicated question. CRNAs can bill patients directly for anesthesia the same amount as anesthesiologists can. Now, I say that with a caveat because it's kind of state dependent on how much you can bill Medicare and Medicaid, which is Medi-Cal in California. But in California anyways, as a CRNA, if you say you're working at like a private surgery center, and every patient that comes in for surgery, they have to pay a bill to have their surgery. And that bill usually incorporates a bunch of things: the bill to the surgeon, the bill for the facility, the bill to pay the nurses who take care of them, the bills to pay the surgical tech, and then the bill for anesthesia. And if you are a CRNA working independently and you're in that model, it's called like a 1099 or private model, then you bill the patient directly and you bill the exact same that an anesthesiologist does. That's actually the way to make the most money as a CRNA. However, there are some politics involved. And so most of those jobs are taken by anesthesiologists because a lot of facilities have this concept that, well, if we could have an anesthesiologist or a CRNA and the pay is the same, then we would rather have a doctor, like a medical doctor. And that's reasonable. A lot of patients kind of expect to see a doctor when they are looking for their anesthesia provider. So there are jobs out there for CRNAs. There's a shortage of anesthesia providers. So there'll always be jobs out there for CRNAs doing that. It's just, it usually takes a couple years of working in a supervised practice, like at UCLA, before people branch out and feel comfortable with that. It's a lot of paperwork to bill your own patients. I personally don't have the time or the patience for it because insurance is a pain in the butt and you often wait 4, 5, 6 months to get paid for those patients. So it's kind of a lot of paperwork and there's some politics involved. Certain surgeries are worth a lot more money than other surgeries. So if you're like the new guy, you're going to get all the crappy surgeries that don't pay a lot until you've been there for a while and can kind of push your way around a little bit more. But in a supervised practice, like at UCLA, where Jillian and I work, we make less than anesthesiologists because our liability is a little bit less. So in a supervised practice, you still are liable. If you kill somebody, you're still going to lose your license or at least get investigated, but you share liability with an anesthesiologist. So like I mentioned, there's like, say, 1 anesthesiologist to 4 CRNAs. Their risk and their liability is 4 times the risk of mine because I'm only at risk for, I'm only liable for the 1 patient I take care of. So in that model, my responsibilities and my liabilities are lower, and I get paid less than they do. That said, CRNAs get paid very well. I want to say, I don't know the average. I would say the average CRNA pay in the country is probably around $180,000 to $200,000 a year. The average pay for an anesthesiologist who works in a supervised practice is probably $350 to $400 a year. But keep in mind that the bills, if you decide to go to medical school, your student loans are probably a little bit higher than they are as a CRNA, because you have to pay for an additional year of medical school is at least one more year longer than CRNA school is. I don't know if I answered that question appropriately.
There are some states where CRNAs can make a lot more, like over 300,000, but they're more like rural places.
And like if I worked my GI job exclusively, I would make like $350,000 a year. I just would die of boredom if I did GI all day, every day. So I don't. I'd rather see a mix of stuff at UCLA. So it kind of depends on what you want to do.
You don't get paid during CRNA school, but you the way my program was structured, the first year we were allowed to do research, and we had classroom, like we had a lot of didactic stuff that you could do on your own time. And so what I did was I still flew back every other weekend to Chicago to work at my ICU job in Chicago from Pittsburgh, because it paid me so well that it covered the cost of my flight and then more. So some people do work like their first year of the CRNA program if it's a 3-year program, but if it's a 2-year program, most people don't, almost nobody works because it's so intensive that they don't have time. Like when you have downtime, you probably just want to relax or see friends and family. But I worked the first year and it was manageable with the 3-year program. But otherwise, we do not get paid during CRNA school. The difference is like with us and doctors is residents do get paid. However, we have a break from school where we work as nurses. So when we work as nurses, we get paid and we can use that money and save that money for school as well. And for balancing studies, you actually gave us a lot of vacation days. We had like 21 days of vacation a year, but I know like some other programs don't give any vacation days. So that's just dependent on, what program you go to and, figure out what works for you.
There's a question about someone who's a physician, an anesthesiologist, or an ICU doctor in a European country like Armenia. Do you know what additional exams or programs you need to take here in the US to work as a CRNA or an anesthesiologist doctor? Or where can we obtain this information? That is a good question that I do not have the answer to. I know in most tracks, a physician in another country has to get permission to do over their residency in the US. I don't know what the medical board in the US, what their agreement is with Armenia. But I've worked with several people who were physicians in India or physicians in like Iran and a couple other places. And usually the requirement is that they come to the US and redo their residency, but don't quote me on that because I really don't know. I don't know if you know, Jillian, I don't know the answer to that.
Nope, I'm not sure.
I know that you can't just like come to the US and immediately work as a CRNA or work as a anesthesiologist, but I'm not sure what all of the, and also, I mean, we can't just go to Armenia or to some other country and work there either. Like we would have to redo, I'm sure, some sort of training to go work in another country as well.
Okay, what's the next step for you guys? Do you want to stay in UCLA? Yeah, I've only been there 1.5 years, so I plan to stay. And I may venture into the private practice world someday like Emily has, but right now I'm pretty happy where I'm at. And I went to University of Pittsburgh for my CRNA program. I chose it because they had a rotation in Cambodia, that I really wanted to do. They gave us a month off to travel around Southeast Asia. So I went to Myanmar, Cambodia, and Laos, and we did pediatric anesthesia over there. And so that is why I chose that program. And they also gave vacation days, and they were really nice. And the city of Pittsburgh is small enough where I had a little scooter and I would scooter everywhere. And that's what I really miss it. What about you, Emily? Why did you choose yours?
I do not have a good story for why I chose mine. I literally, like, it was the only one. I was like, barely had gotten my year of ICU in. Granted, I'd been an ER nurse for 6 years. And I was just like getting my year of ICU in, and I had done my GRE and I had done my like CRNA shadow, and I'd met all the other requirements for applying. But by the time I did that, the only one that still had their applications open was USC, the only one in California. By that point, I was kind of committed to staying in California. So at that point, the only options in Southern California were USC or Kaiser's program, which is part of Cal State Fullerton. And then they were just, I think Loma Linda was just opening, but I hadn't done that much research about it. So literally I was leaving on vacation and I realized that USC still had their applications open. And I applied and submitted my application in the parking lot of Trader Joe's because my internet wasn't working. And so I bootlegged their internet because my aunt worked at Trader Joe's, and I submitted my application really fast. And I was like, there's no way I'm going to get in. I'll probably apply again next year, but I just wanted to like try, well, you know, like slide it, try one time before their applications closed. And by some miracle, I got into the program that year. So I figured if I get in, I might as well take it. So I didn't really do a ton of research and pick and choose where I wanted to go. I kind of just, I needed something in my, I didn't want to move. I was living here in Southern California, so I kind of was limited on my choices. But that said, if you decide, if you're, especially if you're able to travel, do a lot of research, like see what the, like Jillian said, like see what the programs offer, see if there are breaks, see if they, you know, what the culture is like, see if you can interview students that are already there and kind of get a picture of what it's like. That's what I would recommend.
Yeah, I will say in Pittsburgh, the culture was really, really nice and it drew me there. And the other thing that I found out was when you go to school there for a year, you can get in-state tuition. So that made a difference for me too, because you're not paid and you're living off loans. I wanted a city that was cheaper to live in than LA. And I couldn't live at home because my parents would drive me crazy.
Oh, one other tip is also if you are really committed to living like one place after school, it helps to go to school in that area, because you tend to do all of your clinical hours, like your rotations in the OR, at the hospitals in that area. So like when I went to USC, I went to UCLA as a student actually for two different rotations. And I went to CHLA, the Children's Hospital downtown, and I went to like LAC USC County downtown, and Harbor UCLA. So I got to see all the, like, for free. I mean, I didn't get paid, but I also didn't have to pay to like stick my nose in all these different hospitals and kind of learn what the culture is. And by the end of my program, I knew that I wanted to work at UCLA. And I had also, you know, like I told you guys to act like every clinical day is a job interview. I did the same thing. Like I knew I wanted to work at UCLA. So I would show up like an hour before I had to be there and make sure everything was perfect before anybody came into work, so that I knew that I was making a good impression. So it's kind of one of the pros. I mean, obviously Jillian had no problem getting a job here after school, and she didn't go to school here, but depending on what the market is like when you finish school, when I came out of school, it was really hard to get a job for a lot of people. Like half my class didn't have a job when they finished school. It's not that way now. But I was lucky that I went to school in an area where I wanted to live, because it was kind of a shoo-in. I had a job before I even finished school, so it was helpful.
You want to take the next question, or do you want me to do it?
Oh, sure. Sorry. What is a typical work day like for you? Number of assignment, types of cases you work on? That is a good question. I mean, we're speaking kind of just for us at UCLA because that's where we primarily work. There are a lot of, I mean, you can do anything as a CRNA. You can work, like Jillian said, you can just work in an eye center and do cataracts all day, which literally all you're doing is giving like a tiny bit of pain medicine and just like there, you're going to be fine because people are completely awake for their cataract surgery. Or you can be the CR. Like I have a friend who I went to CRNA school with who all she does is open hearts on babies. So she works at Children's Hospital and she is one of 2 CRNAs that work in a team with an anesthesiologist because it's a hard job and they do all of the baby open heart surgeries. So there's a lot of variety. What I personally, like my personal work day, I work I work all 12-hour shifts, kind of like I did as a bedside nurse. So I'll work, like I'll go into work, usually I'm there by 6:30, 6:45 in the morning. And the first thing I do is kind of set up my room to prepare everything for the day. I already usually have looked up my patients on the computer. So I know their medical history. I know what surgery we're going to do. I know any concerns like they have a heart problem or, oh, they have high blood pressure or diabetes. And so I drop all my medications. I go see the patient. And then the day just starts from there. So it's like one surgery after the other. So there may be a day that I'm at a surgery center and I'm doing pretty healthy patients just having like carpal tunnel surgeries, and I'll do like 7 carpal tunnel surgeries. And then when those surgeries are over, I cross the street from the surgery center over to the hospital and they put me in a big spine surgery. So I do a spine surgery, and then the spine surgery finishes and they're like, oh, there's a baby that needs an MRI and the baby won't hold still for the MRI. Can you go down and sedate the baby so the baby holds still for the MRI? So I go downstairs and I go to MRI and sedate the baby. It's kind of like all over the place. And then there are days where all I'm doing is labor and delivery. So I'm just on call and I'm sitting there like drinking my coffee and eating my Cheetos and waiting for a call from the OB nurse. And then the labor and delivery nurse calls me and tells me, oh, there's a patient in labor and she's 4 centimeters dilated and she wants an epidural right now. So then I'm like busy for the next hour, like getting her information and placing her epidural and getting her comfortable. So the days really vary, is all I'm trying to say.
I went to an accelerated bachelor's program called Lakeview College of Nursing, but there are a ton of them out there. You just have to search accelerated bachelor's programs, and they all have different requirements, and they're anywhere from 12 to 16 months usually in duration. And the acceptance rate usually for CRNA school, I don't know, what would you say, Emily, like 10 to 20%-ish?
Okay. Yeah,
Mhm.
usually you can look on their website, I think,
Yeah.
and they tell the percent, right? Yeah.
Mhm. If you search like CRNA school ranking, or like, US News World Report comes out with these rankings, they'll give you all the information on all the programs. And how do we let go, unwind at the end of the day? I watch a lot of TV. What about you?
Yeah, I mean, I come home and I usually have dinner with my husband and yell at my dog. And I often, these days, I try to hit the gym on my way home because I've gotten very lazy and I never go to the gym anymore. So the last few weeks, I've been bringing my clothes with me to work so I can like go straight to the gym after work. But yeah, probably the same as you do, honestly. Just the same as everybody else, trying to relax and get some good sleep.
Oh, most favorite case. You can take that one. Let me think about that.
I know, I have to think about that one. I can say the hardest are the cases that go poorly. There are days that you have a patient, one that sticks out in my mind is a young woman that was 20 something, and she was changing her tire on the 405 on a Saturday morning, very early in the morning. Her tire popped and she was changing her tire, and somebody must have been texting or didn't see her or something and just ran her over on the freeway. And we worked on her for probably 7 hours. We took her to the operating room first, and then we took her to the interventional radiology department to try to stop the bleeding. And we must have given her 30 something units of blood, and she just was bleeding from everywhere. at some point we just finally were like, she's not going to live, and she died. And those days suck, and those days suck as a bedside nurse, and they suck as a CRNA, and they suck for everybody. But you thankfully have a good team that you work with, and everybody at the end of the day, at the end of the case, everybody was like, okay, are you okay? Do you need a minute? Do you need to go take a break, get some coffee, and like regroup so we can move on to the next surgery? Those are probably the hardest ones. I don't know that I have a favorite, to be honest. You, Jillian?
Yeah, I mean, I agree with you. Like, you just never know how your day is going to go. Even if somebody looks good on paper, one of my most traumatic cases was also a really young person that didn't end up, we weren't able to take his breathing tube out, and then we had to do a trach on him, like open an airway, like right here, like put a hole here so he could breathe. So you just never know how people are going to be under anesthesia, which kind of keeps your job interesting. But I don't know that I have a favorite, because the variety is really good. Like, it just keeps you interested in what you're doing. And it's nice because we get to do anesthesia for all types of surgery. It's not just one type or one body part. I imagine I would really enjoy doing OB again, but I don't do OB. So the next question says, is it hard working with anesthesia doctors? I heard they can get a God complex. I think like in different states, they have different, like a different culture, and it varies by institution as well. Like when I was in Pittsburgh, an anesthesiologist had to be there when you were putting a patient to sleep or when you were waking a patient up. But here at UCLA, they don't have to be there. So a lot of times you don't really see them, which is kind of nice because it allows you to be independent and it allows you to do anesthesia the way that you want to do it. The only time that they really get in the way, I guess, is when you feel like you want to do something for a patient, but then they have a different opinion. And I haven't seen so much of that here, but it was more like when I was training in school, because they were just way more hands-on in the state of Pennsylvania. Because in the state of Pennsylvania, CRNAs can't practice independently like they can in California.
Oh, interesting. Yeah, I would say that, I mean, I've worked almost my entire career at UCLA, like 99% of my days in the OR are at UCLA, and we have a pretty good working relationship with our anesthesia doctors. I mean, there are a couple bad apples in every department. As a bedside nurse, there's going to be a nurse that will drive you crazy, or a nursing assistant that will drive you crazy, or a doctor that will drive you crazy. And that's the same with us. But in general, I think we have a pretty good working relationship with the anesthesia doctors, as well as the surgeons, and the nurses. Like, we all work together as a pretty good team. So yeah, I would not say that it's hard to work with them. Like, usually we have like a little chat. Like, I had a very, very sick patient that was trying to die yesterday, and I called the anesthesiologist, who happens to be a very good friend of mine, and he and I sat there and walked through, like, I was like, okay, I just want to make sure, like, see if I'm like, if I want to make sure that I haven't missed something. Like, this is my plan. This is my backup plan. This is my like third backup plan when things go terribly wrong. Like, do you have any other ideas? And he was like, you know what, have this like vasopressor ready. If the patient's like, if the epinephrine doesn't keep their blood pressure up or keep their heart pumping, like, try vasopressin or try. So we have like a pretty good working relationship. And some of our anesthesia doctors are very, very brilliant. Not all of them, but some of them are very brilliant. And it's really nice to have very brilliant people on your team when everybody's goal is to take care of the patient. It's nice to have people working together that care.
And you can definitely learn from each other too. Like, if they like doing something a certain way, you can see how it works, and you pick up things. And that's the benefit, I think, of having different hands on deck. I will say the next question says, how much does GPA matter when applying to nursing school, or how much does nursing school GPA matter when applying? I will say that my nursing school GPA was not super impressive, like not a 4.0. I think it was like a 3.5 or something like that. But I just made sure I was a well-rounded applicant. So I made sure I subscribed to journals, that I was able to talk about the articles in the journals, like during my interview. I made sure I had really good experience and I worked at really big teaching institutions. And I also did a lot of like mission volunteer work abroad with nursing. So I think at least the program that I went to, they looked for well-rounded applicants, and it wasn't so much just like how good are your grades, but they wanted to see what kind of person you were and like how well you got along with other people, and if you were genuinely interested in advancing science.
I do think that a lot of programs have a minimum GPA though, I think, like not like 4.0 obviously, but like 3.2 or 3.5-ish, somewhere in there. A lot of programs have a minimum. So do your best to get good grades if you can. Okay, there's just a reminder from Sophia that we'll be wrapping up in 1 minute. How do you want to start? RBS, if I think you said you wanted to own your own practice, how do you want to start? I personally have no interest in owning my own practice. But people run their own surgery centers. CRNAs run their own surgery centers. I trained actually when I was in school with a guy that owns a like pain clinic up in Glendale area, I think it was. And he's a CRNA and he does injections for people for pain control. And he completely runs his own business. So I couldn't tell you how he went about starting it because it's not really something I've done a lot of research on. But as a anesthesia provider, as a CRNA, you have to have, unless you're just doing pain injections, you basically work for a surgeon or for a proceduralist. So nobody just gets anesthesia for nothing. So you get anesthesia because somebody's having a procedure done. So a lot of people who own their own practice as an anesthesia provider are partnering with a proceduralist, like a surgeon or a dentist or a foot doctor or whatever.
Okay, and the journal that I subscribed to, I don't remember all of them, but I know that one of them was like the American Journal of Critical Care. Like once you become a critical care nurse, you get to be a part of this association, and they automatically will send you their journal articles once a quarter, once a month or so. And you can always use Medscape or UpToDate as resources. Those are really good resources. I don't know if you guys have access to those databases, but they have tons of journal articles on there. But yes, definitely you guys can always reach out if you have any questions. Emily and I will leave our emails in the chat for you guys. And you guys asked really great questions, and we hope you all become nurse anesthetists someday.
Again, I just want to say thank you so much to our speakers and everybody that showed up. Again, Dr. Jillian, Ms. Pinho, we really, really appreciated this. Again, since you guys have such busy schedules, really, I understand how hard it is to take your time away to do something. So just a huge thank you.
Thanks for having us.
And with that being said, so we will be ending the meeting right now. So both